All right, welcome to the lecture on Starling forces. This is a pretty straightforward one, shouldn't take too long, but it's got a lot of important concepts packed into it. So let's get started. So arterioles are resistance vessels, okay? The arterioles are resistance vessels. They're responsible for generating, that resistance generates the perfusion pressure in a sense. Think of it like when electricity flows through a wire and it flows through a resistor or a high resistance wire, it generates a lot of heat. In a similar fashion, when systemic vascular resistance in the arterioles increases, that allows you to generate a higher pressure to allow enough perfusion to get, fluid and fluid exchange to the organs. All right, so that's sort of the role of the arteriole. It's a resistance vessel. And it's responsible for delivering blood at a perfusion pressure, at a suitable perfusion pressure. The veins and the venules are capacitance vessels. All right, they're capacitance vessels. They contain most of the fluid volume. The vast majority of fluid in the body at any given time, if it's not in the inside our cells, it's inside the venules, all right, or the veins more broadly, the venous system. And in between the arterial system and the venous system, so in between the arteriole, which has its precapillary sphincter, you have the capillary. So this sphincter can open and close to decide how much fluid can get into the capillary, but that's beyond the scope of what we're talking about today. And don't worry about the glycocalyx. All I want you to do is sort of visualize you have a high pressure resistance flow zone. You have the capillaries where things sort of even out, and then you have the veins where it's a low pressure zone. All right, that's the main thing I want you to focus on from what I just said. And there's a couple of forces. These are the Starling forces, the hydrostatic force and the oncotic force. The hydrostatic force is the force of fluid on the walls of the vessel. So you can imagine in a high pressure resistance vessel system, by the time you get to the capillary on this side, you have a high hydrostatic pressure because this is a resistance vessel. The arteriole is a resistance vessel. And we're going to talk about why the fluid doesn't leak out of the arteriole in a second. But in the capillary, that high pressure allows fluid to extravasate into the interstitial space. All right, so the fluid and all the nutrients in that fluid are going to move into the interstitial space. All right, that's hydrostatic fluid. Hydrostatic force, it comes from the fluid. The oncotic force, so onco means protein. So the oncotic force is a concentration gradient developed by the presence of proteins in the plasma. So you have albumin hanging out in the capillaries, and the level of albumin stays the same throughout. So I would just sort of slightly disagree with how this is being drawn here, because in reality it looks more something like this, where these are the two forces, and here's the oncotic pressure, because the amount of albumin in the blood really should not change, unless you have nephrotic syndrome, but that's a totally different wheelhouse altogether, and we're not going to talk about today. And so that's the oncotic force, and the hydrostatic force is something like this. It starts high, and then it drops down. All right, and then it sort of comes back up. All right, that's sort of the difference. And we'll talk about this in a second. But focusing over here at this point on the curve, that would be right when we enter the capillary. So the force of the fluid on the walls of the vessel is stronger than that suction force by these proteins. So these proteins establish like a concentration gradient that wants to bring fluid back inside the vessel. But at the beginning, where we're over here, that force is not going to be stronger than the hydrostatic force. So this is the net difference, and this favors out. Anytime we're above this, the hydrostatic force is above this line, fluid is going to move out into the interstitial space. Anytime the hydrostatic force is below this line, fluid is going to move in from the interstitial space into the capillary. All right. So, and then we move, as we move down along here inside the vessel, as we move down along here, notice we have less and less fluid, so less and less hydrostatic pressure, but the oncotic pressure is staying the same. At this point, there's no fluid exchange, But then what happens? The oncotic pressure rises above the hydrostatic pressure, right? And it's not because the oncotic pressure is rising. I think the better way to say it would be the hydrostatic pressure is falling below the oncotic pressure. All right, so that suction force has been the same the whole time, but now because you lost fluid, the hydrostatic pressure has gone down. And then the hydrostatic pressure will slowly come back up. I don't know if it'll quite do it the way I drew it here, but it'll slowly start to come back up as fluid re-enters. What do you call it? As fluid re-enters the venous side of the capillary. Now, something I want to draw, you might be wondering, okay, well, why is the fluid not leaking back out at the veins again? Why is it not leaking at the arteriole? Well, that's because of this part of the term. So note here, what we just described is filtration, all right? And filtration is the result of that net difference between the hydrostatic pressure in yellow, okay, and the oncotic pressure here in black. And what I drew here represents the vessel. Remember, the interstitial space will have its own hydrostatic pressure and its own oncotic pressure too. So what determines filtration is, first of all, that net hydrostatic force. So how hard is the fluid on in the capillaries trying to push on this wall versus how much is the fluid. So how much is the fluid in this capillary pushing on the wall versus how much fluid in the interstitial space is pushing on this wall, and the difference between those is going to be the total hydrostatic pressure. And then you have the amount of protein in the capillary that has its own suction force into the capillary, and then you have the protein in the interstitial space, which has its own suction force into the interstitial space. And the difference between those is your net oncotic pressure. This term sigma represents sort of the ability of things to cross the membrane, but don't worry about that too much. And Kf represents a filtration constant that it has to do with the basement membrane. So these two terms, don't worry about them right now because they're beyond the scope of our discussion. They're different and they cover different things, but the general way to think of those is that describes how permeable the membrane is to fluid and to proteins. All right. And this filtration factor, this Kf, it's not that effective in the arterioles and in the veins. So that's why fluid doesn't leak out. But the capillaries are designed, and some capillaries are leakier than others. So some capillaries don't have holes in them, right? Like the ones in the brain. They leak, but not too much, and there's a very rigorous blood-brain barrier. Some parts of some capillaries are just like have very wide openings, like in the liver. So you can imagine a lot of stuff can pass through, which is important when you consider what the liver's job is to detoxify. So you want the capillaries to sort of have a lot of openings. And then you have capillaries that have openings but smaller, that allow some things through but not a lot. Those are called fenestrated capillaries. So all the different types of capillaries have different filtration constants. All right. So that's sort of a big shotgun approach. I'm just going to break this back down. We talked about it on a deeper level. I'm going to bring it back to the basics that I think is most important for you to understand right now. Arterioles have a high pressure, and that high pressure is coming into the capillary side, and there's a lot of fluid, and it's going to extravasate out, okay? Until the point where this hydrostatic pressure that's pushing fluid out cannot surpass this steady suction force coming from the albumin in the capillary, this oncotic pressure. And at that point, fluid will start to return. All right. So that's sort of it. All right. At any given time, what will decide whether fluid enters the vessels or leaves the vessels, it's decided by the hydrostatic versus the oncotic, okay? Whichever one, if hydrostatic is higher or lower than the oncotic, it'll determine whether fluid will exit or enter the vessel. Okay, so I want to talk about the edematous states. In the edematous states, fluid leaves the vessels and it accumulates in the interstitial space. So when fluid leaves the vessels and accumulates in the interstitial space, we refer to that as an edematous state. And to understand the edematous state, and there's a couple of different conditions that can cause it, but I'm just going to focus on three. we have to look at this equation. All right, we have to look at this equation. And essentially, remember that filtration is equal to the difference between the hydrostatic and oncotic pressures multiplied by the permeability of the membrane. All right, so if this membrane permeability goes up, whether it's because of damage to the endothelium, which is what lines the vessels, whether it's because of, physiologically, because of inflammation, the vessel becomes leaky. That's a natural part of inflammation. The endothelium becomes more leaky during the innate immune response. And that's why a lot of responses to injuries is swelling. What does that swelling represent in an injury? It represents vasodilation by the vessel, all right, so that you have slower blood flow through the area, but also an increase in the permeability of the vessels. So not only is the fluid moving more slowly, it's leaking out. It's moving slow enough to accumulate and then leak out into the interstitial space. And that's why you get swelling with infection and with injury. All right, so that is when KF is going to increase. Let's look at the hydrostatic pressure. When would hydrostatic pressure increase? Well, when fluid builds up, when things start backing up, like in congestive heart disease, etc., you get an increased hydrostatic pressure because of a lot of fluid. All right, or in cases of like hypertension, like malignant hypertension, you can get damage. Well, that's actually, I'm going to walk that one back because you get damage to the endothelium in malignant hypertension. Yes, you'll have higher hydrostatic pressure, but the pressures become so high in malignant hypertension that the vessels die. You get fibrinoid necrosis or destruction of the vessels. So that's sort of going to be a mixed picture. But don't memorize anything of what I'm saying now. I'm just giving some broad examples, and there's 3 I'm going to hone in on that you really need to know. In oncotic pressure, well, that's going to be any state in which there's less albumin circulating in the capillary. And that's going to happen in 2 states, and we're going to talk about both of them. The first is a nephrotic syndrome, where you lose protein in the urine. So the kidneys are not supposed to lose protein, but when you have inflammation of the kidneys and damage to the glomerulus, albumin can leak out. And the consequence of that is edema. Okay, you get this fluid buildup in the vessels because you're losing albumin in the blood. And when you lose albumin in the blood, when you lose albumin in the urine from the blood, the albumin in the blood goes down and the oncotic pressure is going to go down. And you're going to be subtracting oncotic pressure from hydrostatic pressure. So if this goes down, this whole term becomes more positive, representing more filtration. All right? So to summarize, if permeability increases, KF increases. And because KF is sort of the multiplier for this, this subtraction, if this goes up, the whole thing goes up. If this first term increases, the whole filtration increases. And what's the first term? Hydrostatic pressure. The second term that's being subtracted from the first, if this decreases, this whole term increases. All right, so think of it, you can think about it mathematically. So let's go to the first state that I want to talk about, which is, I sort of already started talking about it, which was the nephrotic syndrome. All right, nephrotic syndrome. So all I need you to know about this right now, there's a lot about this, and there's a lot of different autoimmune conditions and inflammatory syndromes that cause this. But what I want you to understand right now is that in the nephrotic syndrome, the basement membrane of the capillaries in the glomerulus are messed up. So the KF in the glomerulus is going to be higher, but only in the glomerulus. And don't worry about that too much right now. The bigger picture is that because the glomerulus has become more leaky, its basement membrane is no longer intact, it's going to leak protein that it should not be leaking. And as a result, you're going to lose albumin in the urine. All right. And when you lose albumin in the urine, there's less that's going to be circulating in the plasma. All right. So this term goes down. Oncotic pressure goes down. And because oncotic pressure went down, you're going to have less of an incentive to pull fluid back in on this end, right? Because hydrostatic force is stronger here. So if we were going to draw our graphs, let's go ahead and draw our graph. Okay, before, this black line represents oncotic pressure before, hydrostatic pressure sort of does this, then comes back up as fluid is, reabsorbed. But in nephrotic syndrome and in liver disease, and we'll talk about why in liver disease in a second, in liver disease, the new line is going to be in purple. Your threshold is now here. All right, so now there's a lot more room to lose fluid. All right, this is your new threshold after you've lost albumin. All right, so in liver disease, you actually make less albumin because the liver makes the albumin. So if the liver is diseased, you don't have as much albumin, and it's the same idea. The new line is down here, and now hydrostatic pressure is significantly higher than the oncotic pressure, resulting in more fluid extravasation into the interstitial space, and you can get portal hypertension, and that's its own topic that I'm not going to go into. But the main point I'm trying to point out here for the oncotic pressure is that it can decrease as a result of two things. Either you're making less albumin or you're getting rid of albumin. If you're getting rid of albumin, that's sort of what's going on in the nephrotic syndrome when you're losing protein from the kidneys, because you're not supposed to lose protein in the kidneys. In nephrotic syndrome, there's damage to the basement membrane and you lose that protein. In liver disease, there's damage to the liver and it's not making the albumin. All right, and in both of those conditions, the albumin levels are going to decrease in the plasma. That is going to cause oncotic pressure to decrease in the capillaries, and so you're not going to have that suction force, as strong of a suction force as is shown right here. The suction force is going to decrease, so this hydrostatic pressure is going to be higher. At any given point, compared to before, the hydrostatic pressure is higher. So if it was this much higher before, it's this much higher after. All right, so that's the oncotic part. And before we go to the next slide, let's talk about some things that are increased KF, just to circle back to it. I'd mentioned a few. What I want you to think of is any time the permeability of the membrane is going to increase, whether it's because of damage or because of inflammatory mediators as part of an immune response, that is going to cause edema and fluid extravasation. A very important example that comes to mind for me is acute respiratory distress syndrome. So normally the alveoli, right, are filled with gas, and they have a tiny like fluid surfactant layer. It's more like an oil that keeps everything open. What happens in acute respiratory distress syndrome is you get inflammation, very strong inflammatory cytokines, and it ravages the alveoli, and they begin to fill with this hyaline. Don't worry about this term, but the buzzword on board exams is hyaline exudate. Focus on the exudate part right now. Why is there an exudate? Because the inflammation destroyed the basement membrane of the alveoli. This KF increased. This alveolus fills with fluid. And if it's filled with fluid, you know what it's not filled with? Gas. You know what that means? You have dead space. You have alveoli that are receiving blood, but there's no gas inside to exchange with it. What happens as a result of that? Death. You have ventilation perfusion mismatch. You have hypoxia because the amount of oxygen in your blood goes down, because the amount of air that's actually coming in, it doesn't actually exchange with the blood, because the alveoli, because of the damage to the membrane, it's become more permeable. It's filled with fluid. If it's filled with fluid, it's not filled with the respiratory exchange gases. All right, that's important. So that represents KF. That's a good example of KF that I want you to know. And oncotic pressure we just talked about. So lastly, we're on the hydrostatic pressure component. And I think a very easy example of this is going to be congestive. Don't ask me why the C came out that large, but it's going to be congestive heart failure. All right? So in congestive heart failure, think of the heart as like a pump, which it is, but think of it as a pump, and the sarcomeres of the heart stretch to accommodate the pump. Remember, you have this sort of, let's say this is the scaffold on which actin and myosin are, and then here you have actin and the other one's myosin, and you sort of have them interacting together. Actin and myosin interact, and there's going to be stretch, etc. So what happens in the heart, and this is called the Frank-Starling mechanism, don't worry about it too much now, there'll be a different lecture going to detail. But generally speaking, what happens is as the heart stretches, so as this here stretches, it gets more elastic. It's kind of like a rubber band, where you pull a rubber band and it wants to snap back. That's kind of what happens in the heart. So the healthy heart increases how strongly it contracts depending on how much fluid extends it. But let's say you have a weak heart. Let's say, for example, you've had a heart attack and there's major damage of infarcted tissue in the heart, right? So your ventricle isn't, which is, what pushes blood into your circulation. The ventricle isn't as powerful anymore. So when you're resting, and the fluid, sort of the demands of the body on the heart are the same, there's not too much of an issue because the heart still works. But that damaged ventricle, let's say you were to stretch it with more fluid or increase demand, what's going to happen is that it's not going to contract as strongly. So the ejection fraction, or the amount of fluid it can eject, is going to go down. So you can kind of imagine this pump that's overwhelmed. It's not pumping well. The Frank-Starling mechanism isn't intact. In other words, yes, the sarcomeres stretch, but then they don't really contract that well, and fluid isn't really being ejected out of the heart, and it's building up in the left ventricle. It's building up in the heart, and then it's building up in the lungs, and you get this pulmonary edema, this shortness of breath. People start having to put pillows behind their back to sleep. And then that pressure builds up everywhere else, and not the pressure, sorry, the fluid begins to build up in the heart. Then it builds up in the lungs. All right, well, what does that build up do? When you start building up all that fluid, there's more fluid pressing on the walls of the vessels. And this is a gross oversimplification, but I'm grossly oversimplifying it, but what happens is that fluid buildup means that fluid is going to be able to push more on the walls of the vessel, and it's going to leak out. So the first place that's going to happen, so here's the heart. Remember, what comes before the left ventricle? The left atrium. And what happens from the left atrium? Blood returns to the lungs. And not returns to the lungs. The blood comes from the lungs into the left atrium. So if fluid builds up in the lungs, in the capillaries of the lungs, the hydrostatic pressure of that fluid is going to increase, and you'll get infiltrates into the lung itself. All right, so the lung starts to fill with fluid. All right, and you'll see that on an X-ray. It's called like infiltration, infiltrates. But don't worry too much about that right now. What I'm trying to paint this picture of is just, fluid backing up. You get pulmonary edema, and then remember, before the lungs comes the right ventricle, and then before the right ventricle is the right atrium, and before the right atrium is the rest of the body. And the rest of the body is going to experience swelling, especially the parts that are most affected by gravity, like the lower legs. So you get this edema, this swelling in the lower legs, but in this case, it's because hydrostatic pressure has kind of built up. And don't confuse hydrostatic pressure with perfusion pressure right now, okay? The blood pressure is actually going to be lower, especially if it's decompensated heart failure. The heart is not pumping strongly, so that driving force on the arterial side is not that strong. All right? Because the heart is failing. So your perfusion pressure is not going to be that as high. But the hydrostatic pressure, so not in the arterial system, but think in the veins, in the capillaries before the veins, right? That's the big one. The fluid builds up in the veins, and then it builds up in the capillaries before the veins, and the fluid leaks out. That's what's going on in heart failure. All right, so the hydrostatic pressure has increased because of that fluid buildup. All right, so we've talked about, so just to erase everything and to summarize, because we talked about a lot here. Arterioles are the delivering vessel. They bring fluid at a high perfusion pressure into the organs. That perfusion pressure is important for supporting the hydrostatic pressure. So the hydrostatic pressure sort of depends on how much fluid is in here and how much force the fluid is exerting on the walls of the membrane. So that's what the arterioles are for, and then blood goes through the capillary. And then in the veins, those are the capacitance vessels. That's where most of the fluid volume is stored at any given time. So in the outside of it, there's the intracellular compartment and the extracellular compartment. Outside of the cells, most of the fluid is usually in the veins. All right. And what determines whether fluid moves in or out of a capillary are the Starling forces, the first of which is hydrostatic pressure, which, like we said, is from the fluid, or the oncotic pressure, which is from the albumin that hangs out inside the plasma. Okay? And it's the difference between the force of the fluid and the force of that suction force of this protein that determines whether fluid goes in or goes out. If the permeability of the membrane increases, then it's easier for fluid to get out. All right, so the states in which filtration will increase are when the permeability increases, like in membrane damage or in inflammation, in hydrostatic increases, like as occurs with congestive heart failure, and in states of oncotic decrease, all right, which occurs with liver failure because you're not producing albumin anymore, and with nephrotic syndrome because you're losing the albumin in the urine. All right, good luck.